Our final biliary presentation is by Dr. Mohan Ramchandani. He is Director of Interventional Endoscopy at the Asian Institute of Gastroenterology Hospitals in India, and he is an expert in EUS, third space endoscopy, and ERCP. Dr. Ramchandani will be talking about interventional EUS in the minimally invasive management of cholecystitis.
At the outset, I thank Professor Raj Shah and Dr. Sachin Vani for giving me this opportunity to speak in this forum. I will be speaking about role of interventional EUS in the minimally invasive management of cholecystitis. Laparoscopic cholecystectomy is the treatment of choice for acute cholecystitis. However, early or emergency surgery may not be always possible. Either it may be because of unavailability or patient presenting as severe cholecystitis and organ failure may not be ideal patient for cholecystectomy. Patients who are not operative candidate because of the comorbidities also are not advised to go cholecystectomy. In such situation, we adopt a drainage strategy, and the drainage can be done either by percutaneous methods or endoscopic methods. The percutaneous method is widely available and can be performed bedside. However, it is associated with frequent adverse events, especially the tube dislodgement, and this may not be a long-term solution as the quality of dive diminished as the catheter is kept for a long time. That is why the endoscopic modality of drainage is the second option. The endoscopic drainage can either be done by ERCP and putting a transpapillary stent from the papilla into the duodenum, or putting a nasocystic drain, or another method of doing drainage is to create a transmural tract between the gallbladder or duodenum or stomach. The advantage of the transpapillary drainage is that it does not require any external catheters and can be performed in patients with ascites or coagulopathy. It also allows us to treat simultaneously the bile duct stone. However, this method is technically difficult and is not widely available, and it may be associated with post-ERCP pancreatitis. The peroral endoscopic transmural drainage, as I said, is performed by EUS guided method, and this may allow placement of a stent with larger diameter and permit endoscopic extractions of gallstone. This procedure is not widely available, that is its biggest disadvantage, and it may interfere with subsequent surgeries. So the indication of EUS guided gallbladder drainage is now expanding, and the indication may include those patients who are non-surgical candidates with or without gallbladder stones, which can be extracted using this method also. This method can be used as a bridge to surgical cholecystectomy. We can also use this method to convert the percutaneous gallbladder drainage to internal drainage by putting a stent across the duodenum or stomach into the gallbladder. This can be also used as alternative when we have failed in percutaneous gallbladder drainage or transpapillary gallbladder drainage. If the cystic duct is patent, this method also can be used as EUS guided biliary drainage and can be an alternative to ERCP. The advantages and disadvantages of EUS guided gallbladder drainage include that it provides an internal drainage compared to percutaneous drainage, and it is technically simple. While the problem here are that the long-term follow-up are still not clear, and there is insufficient evidence on EUS guided gallbladder drainage as first-line drainage. The technique involved we'll be discussing in details. First of all, let us discuss what are the stents which can be used. The plastic stents are cheaper and available everywhere. However, they may be associated with bile duct leak, biliary leak, and there can be a shorter patency. If the patient is likely to undergo cholecystectomy at later date, plastic stent may be preferred over metal stent. The fully covered metal stent can also be used in this situation where it prevents biliary leak and the stent patency is slightly longer. We can also put plastic stent, double pigtail stent through these fully covered longer stent to prevent migration. They are less likely to cause adverse event than plastic stents. But the most commonly used stents nowadays are biflanged or lumen opposing metal stents. They have larger diameter and have a better drainage, and their flanges prevent migration. So the site of puncture for gallbladder drainage can either be a stomach or duodenum. In stomach, it is easy because we have a larger diameter of the gallbladder, because we will be approaching the body of gallbladder and there is an ample space available for the stent to expand. The easier deployment of inner flange, that's why happens because of the larger room available. The rescue surgery is easy when you choose stomach as the puncture site. The disadvantage is that the gallbladder here is more mobile and there can be a stent migration, and subsequently when the stent expands there can be a food reflux. The advantages of duodenal approach is that it is less, the gallbladder is more fixed here, there is a less mobile structure and the wall is more closer to gallbladder, there is less food reflux, but the difficult surgery when the rescue is required, and it is slightly technically difficult. However, the studies comparing transgastric or transduodenal EUS guided gallbladder drainage, no significant differences in technical or clinical rates have been reported. Let's talk about the procedural details. The gallbladder drainage can be done by 3 methods, and one has to keep in mind the technical challenge which we will be encountering. One is the gallbladder is a mobile structure and there is a risk of gallbladder being moved away from stomach or duodenum. So the initially technique which was defined was Seldinger technique, which we will discuss. Then came the one-step freehand technique, and one can use as a hybrid freehand lamps insertion technique which combines this with the speed of freehand technique and the safety of wire guided techniques. So let us discuss one by one. So this is the technique which was adopted in a patient who is 60-year-old male, as presented to us with obstructive jaundice. He underwent ERCP and there was a lower CBD stricture, and the stenting was done, brush cytology was taken. The patient again presented with severe fever and there was acute cholecystitis post ERCP, and we planned a gallbladder drainage. As you can see, it's a transgastric puncture, and there we are puncturing this is a needle which has gone in, 19 gauge needle is used. Followed by that, you can see a bile duct stent over there, and then the wire is passed through this the 19 gauge needle, similar to the what we do in pseudocyst or a wand drainage. The initial dilatation was done by a cystotome, followed by a balloon dilatation was done, and a Nagi stent was placed, just like what we do in a pseudocyst drainage. So it's almost like similar to pseudocyst drainage. So this is the stent which has completely opened up, and there is a air in the gallbladder which is communicating with the gastric antrum. The second technique, which is freehand technique, and it uses cautery enabled hot stents. Here you can see this is a patient with acute cholecystitis and has presented with sepsis and hypotension, and is a not candidate for immediate cholecystectomy, and you can see there is a thickened gallbladder wall. So the scope should be repositioned to find a suitable window. There we can see there is a lever coming between the gallbladder and the gastric wall over there, and then as you move the scope, reposition the scope, you will find a proper position. The distance from the gastric wall and gallbladder needs to be measured, and it is not appropriate at this place. So we position the scope more closely, and now you can see the gallbladder is almost coming very close to the gastric wall. The Doppler signals are seen, and then we rule out any intervening blood vessels. And this hot EXIOS, which is being used here as a quatry enabled stent, and a pure cut current of 100 watt spec 5 is being used, and it punctures the gallbladder wall, and then inner flange is deployed inside the gallbladder, and you can see there is a capacious gallbladder over there. Once the inner flange is deployed, the catheter is pulled back to create a tenting and obtuse angle over there, and once a distal flange is deployed, rest of the stent is deployed under vision endoscopically, and you can see copious amount of pus and small stones which are extruded are being seen. And this is how a drainage is performed. And here we have used 10 millimeter stent. You can use 15 millimeter stent also and do the balloon dilatation, and subsequently we can go inside the gallbladder and drain. Here we have put a plastic stent to ensure the drainage, because we were not dilating. The patient was very sick, and the plastic stent was placed. Since no dilatation was done, we just do not want the stone to obstruct the lumen of the stent. That's why a plastic double pigtail stent was placed. Another method is transduodenal method, where we use a same technique, but this is a long scope position, and the catheter is, you can see here, the echo endoscope is facing towards the porta, and you can see here directly a different stent. This is not lumen opposing, but it's a biflanged large lumen stent is being punctured. Again the same technique, the distance between the duodenum and gallbladder is measured. A Doppler signal rules out the intervening vessels, and subsequently the distal flange is deployed and the proximal flange is deployed endoscopically. You can deploy under your vision, or you can deploy it inside the channel and push the deployed stent out. And you can see here, similar to the Vaughan drainage or pseudocyst drainage, you can see immediate relief. There is a lot of pus being discharged there. Sometimes once the patient is on long-term percutaneous drainage, one can use a plastic stents in similar fashion to convert the external drainage to the internal drainage. Here again, that's a 19 gauge needle we punctured, and then subsequently a wire is passed. You can inject the contrast to make sure the gallbladder is there, and then this is the percutaneous catheter which is already in place, and subsequently after dilatation by a balloon, we inserted a plastic stent, and the external drainage was converted into internal drainage. So that is the advantages of endoscopic ultrasound guided gallbladder drainage, and the outcomes are very good. The technical success varies from 84 to 93 in various trials, including one prospective trial which was published, and also many retrospective studies have shown the clinical success rates in the tune of 95%. This network meta-analysis showed comparison of percutaneous gallbladder drainage versus transpapillary drainage and the transmural drainage, that is the EUS guided gallbladder drainage, and these all patients were of acute cholecystitis with high risk for cholecystectomy, and overall 1267 patients were included. And this network meta-analysis confirmed that EUS gallbladder drainage is associated with highest technical and clinical success. There is lowest rate of recurrent cholecystitis, The percutaneous drainage is having highest rate of reintervention and unplanned admission, while the transpapillary drainage was associated with lowest mortality. The highest level of evidence is randomized control trial, and this was published by Professor N. Teo from Hong Kong, and they did a multi-center study using EUS guided gallbladder drainage versus percutaneous cholecystostomy in very high risk surgical patients. So these patients never underwent surgery with acute cholecystitis, and this was a randomized control trial including 39 patients in EUS guided gallbladder drainage arm versus 40 patients in percutaneous drainage arm, with the primary endpoint of 1 year adverse event. And this study has shown that the 1 year adverse event, the reintervention after 30 days, the unplanned admission and 30 days adverse events were significantly less in EUS guided gallbladder drainage arm as compared to percutaneous arm. However, the technical success and clinical success were equal in both the arms. This study also showed that the EUS guided drainage, if you compare it with transpapillary drainage, there is higher technical success with EUS, higher clinical success and overall lower recurrence rates as compared to the transpapillary arm. In comparison to percutaneous gallbladder drainage, the EUS has similar efficacy and safety and lower reintervention rate, similar to what the randomized control trial has shown. The complications are by and large less. This procedure is relatively safe with minimal complication in experts, and the pooled analysis reporting complication rates, the rates have varied from 8 to 17%, and the complication includes bile leakage, stent migration into gallbladder or peritoneum, bleeding, gastroduodenal perforation, pneumoperitoneum or recurrent acute cholecystitis due to stent occlusion. And this is the meta-analysis which was published and has shown the overall adverse events are around 13% with LAMS in EUS gallbladder drainage studies. Early adverse event risk is 6.5%, while the delayed is 8%. So in conclusion, I will say that EUS guided gallbladder drainage is an accepted minimally invasive non-surgical therapeutic option for management of high-risk patients with acute cholecystitis. Development of single-step EUS-guided LAMS delivery systems have made procedure simpler. EUS-guided gallbladder drainage can be associated with potentially serious complications, though they are rare. There are many unanswered questions like what is the best type of stent, what is the preferred site of gallbladder puncture, what are the long-term consequences and management of both stent as well as gallbladder after resolution of the symptoms. But EUS guided gallbladder drainage is now inching towards prime time. With this, I thank for patience hearing, and will be happy to participate in question answer session. Thank you very much.